Welcome to Pediatric Case Review. Today we present a comprehensive case-based review of long-chain 3-hydroxyacyl-coenzyme A dehydrogenase deficiency, commonly abbreviated LCHAD deficiency, prepared for general pediatricians. This is a long-chain fatty acid oxidation disorder where early recognition can be life-changing, and it has a distinctive feature, retinopathy, that sets it apart from other similar conditions. Across this lecture, we will work through 14 clinical cases, covering the clinical presentation, newborn screening and acyl-carnitine findings, the underlying biochemistry, the eye and nerve complications, the diagnostic workup, dietary and emergency treatment, and the important maternal pregnancy complications. Let us begin. Question 1. A 3-week-old male presents after 6 hours of fasting during a viral illness. He is lethargic, hypotonic, and pale. Heart rate is 178, respiratory rate is 52, and temperature is 38.1 degrees Celsius. Glucose is 1.8 millimoles per liter. The pH is 7.18, and lactate is 6.2 millimoles per liter. Urine ketones are negative. There is hepatomegaly of 4 centimeters, and echocardiography shows dilated cardiomyopathy. What is the most likely underlying metabolic disorder? Option A, medium-chain acyl-coenzyme A dehydrogenase deficiency. Option B, glycogen storage disease type 1, von Gierke disease. Option C, long-chain 3-hydroxyacyl-coenzyme A dehydrogenase deficiency. Option D, propionic acidemia. The correct answer is option C, LCHAD deficiency. The key clue is hypoketotic hypoglycemia. The infant is hypoglycemic during fasting, yet the urine ketones are negative because impaired fat oxidation cannot generate ketones. This is the classic hallmark. There is also metabolic acidosis with a high lactate, reflecting energy failure at the cellular level from mitochondrial dysfunction. Critically, there is dilated cardiomyopathy in a neonate, which points to LCHAD or another long-chain fatty acid oxidation disorder, and is not seen in medium-chain acyl-coenzyme A dehydrogenase deficiency. Hepatomegaly results from fat accumulation in the liver cells from unprocessed long-chain fatty acids. Medium-chain deficiency lacks cardiomyopathy. Von Gierke disease has different biochemistry, and propionic acidemia shows an organic acidemia pattern without this fatty acid oxidation picture. Question 2. A 72-hour-old female newborn, born at 38 weeks, is asymptomatic and breastfeeding well. Routine newborn metabolic screening returns with a flagged result, and the laboratory contacts the birth hospital requesting urgent follow-up. Which acyl-carnitine finding on tandem mass spectrometry most specifically suggests LCHAD deficiency? Option A, elevated C16-hydroxy and C18:1-hydroxy, the 3-hydroxy long-chain acyl-carnitines. Option B, elevated C8, octanyl-carnitine. Option C, elevated C14:1, tetradecinyl-carnitine. Option D, elevated C3 and C4 dicarboxylic, propionyl and methylmalonyl-carnitine. The correct answer is option A, elevated C16-hydroxy and C18:1-hydroxy acyl-carnitines. The defining feature is the hydroxyl group on these long-chain acyl-carnitines. Because the LCHAD enzyme is blocked, 3-hydroxy long-chain acyl-carnitines accumulate, and that hydroxyl group is the unique biochemical signature of LCHAD. As a quick differential reminder, elevated C8 points to medium-chain deficiency. Elevated C14.1 points to very long-chain acyl-coenzyme A dehydrogenase deficiency, and elevated C3 with C4 dicarboxylic points to propionic acidemia or methylmalonic acidemia. Newborn screening detects this before symptoms appear, which is a critical window for preemptive treatment. Any positive screen requires urgent referral to a metabolic specialist, even if the infant looks completely well, and confirmatory testing is needed because false positives do occur. Question 3. During a teaching session for pediatric residents, the attending explains why LCHAD deficiency causes a distinctly different pattern of organ damage, including retinopathy and peripheral neuropathy, that are not seen in medium-chain acyl-coenzyme A dehydrogenase deficiency. Which mechanism best explains the unique organ damage pattern in LCHAD? Option A, severe hypoketotic hypoglycemia causing neuronal death. Option B, autoimmune destruction of mitochondria in target organs. Option C, deficiency of acetyl-coenzyme A impairing Krebs cycle function. Option B, accumulation of toxic long-chain 3-hydroxyacyl metabolites causing direct cellular toxicity to the retina, myocardium, and peripheral nerves. The correct answer is option D, direct cellular toxicity from accumulated long-chain 3-hydroxyacyl metabolites. When the LCHAD enzyme is blocked, long-chain 3-hydroxyacyl metabolites, the C16-hydroxy, C18-hydroxy, and C18:1-hydroxy species, build up. These metabolites are directly toxic to specific tissues. In the retina, they cause photoreceptor degeneration, leading to pigmentary retinopathy. In the myocardium, they cause cardiomyocyte damage, leading to dilated or hypertrophic cardiomyopathy. In peripheral nerves, they cause Schwann cell damage, leading to a sensory motor neuropathy. This is the key concept. Medium-chain deficiency accumulates medium-chain metabolites, which are not toxic in this way, so it produces no retinopathy and no cardiomyopathy. The toxicity is from the metabolites themselves, not simply from low glucose. Question 4. A 6-month-old girl with LCHAD deficiency has been on dietary treatment since day 5 of life. Her parents report decreased visual responsiveness. On examination, she has hypotonia, hepatomegaly, and a notable fundoscopic finding. Which fundoscopic finding is most characteristic of LCHAD deficiency? Option A, progressive peripheral pigmentary retinopathy with a salt and pepper or bone spicule pigmentation. Option B, a cherry red spot at the macula, as seen in Tay-Sachs or Niemann-Pick disease. Option C, optic nerve pallor and atrophy without peripheral changes. Option D, cotton wool spots and flame hemorrhages, as in hypertensive retinopathy. The correct answer is option A, progressive peripheral pigmentary retinopathy. Roughly 80% of LCHAD patients develop pigmentary retinopathy, and this is unique among all the fatty acid oxidation disorders. The pattern progresses in stages. It begins with peripheral salt and pepper pigmentation, advances to bone spicule deposits, then to central macular atrophy, and can ultimately cause legal blindness. Electroretinography is key because it detects cone and rod dysfunction before any visible changes appear on the fundus, making it the earliest diagnostic tool. Docosahexaenoic acid supplementation may help slow progression, and an annual dilated eye examination with electroretinography every 2 to 3 years is mandatory. The take-home point is that LCHAD is the only common fatty acid oxidation disorder with retinopathy, and that is a critical distinguishing clinical feature. Question 5. A 4-month-old male infant is admitted for his second episode of hypoketotic hypoglycemia with a glucose of 1.5 millimoles per liter, lethargy, and elevated liver enzymes, with an alanine transaminase of 285 units per liter and an aspartate transaminase of 320 units per liter. LCHAD deficiency is suspected, but the newborn screening result was lost. Which investigation provides the definitive diagnosis of LCHAD deficiency and differentiates it from complete trifunctional protein deficiency? Option A, liver biopsy with electron microscopy showing mitochondrial abnormalities. Option B, urine organic acid analysis showing elevated 3-hydroxy-dicarboxylic acids. Option C, enzymatic assay in fibroblasts showing isolated LCHAD deficiency with preserved other activities confirmed by HADHA molecular genetic testing. Option D, plasma acylcarnitine profile showing elevated C16-hydroxy only. The correct answer is option C, the enzymatic assay in fibroblasts together with HADHA molecular genetic testing. The diagnostic pathway has several steps. Plasma acylcarnitines showing elevated C16-hydroxy, C18-hydroxy, and C18:1-hydroxy are suggestive, but not definitive. The enzymatic assay in fibroblasts is essential. In isolated LCHAD deficiency, only the LCHAD activity is deficient, while the hydratase and thiolase activities are preserved. HADHA molecular testing then confirms biallelic pathogenic variants in the HADHA gene. This matters because the acylcarnitine profiles are identical in LCHAD deficiency and in trifunctional protein deficiency, so the acylcarnitine profile alone cannot tell them apart. In complete trifunctional protein deficiency, all 3 enzyme activities are deficient, and the gene involved may be HADHA or HADHB. The common LCHAD mutation is C.1528G to C. So the enzymatic assay is what distinguishes isolated LCHAD deficiency from trifunctional protein deficiency. Question 6. 4 children present to the metabolic clinic, each with a fatty acid oxidation disorder. Patient A is an 18-month-old male with hepatomegaly, a newborn screen showing elevated C8, no cardiomyopathy, and hypoketotic hypoglycemia. Patient B is a 2-year-old male with hypertrophic cardiomyopathy, a screen showing elevated C14:1, a severe form, and no retinopathy. Patient C is a 6-week-old female with cardiomyopathy and retinopathy, a screen showing elevated C16-hydroxy, neonatal collapse, and developing retinopathy. Patient D is a 3-year-old male with exercise intolerance, a screen showing elevated C14:1, rhabdomyolysis, and no cardiomyopathy. Which patient's presentation is most consistent with LCHAD deficiency? Option A, patient A. Option B, patient B. Option C, patient D. Option D, patient C. The correct answer is the option labeled D, which corresponds to patient C. Patient C is the 6-week-old with a combination of neonatal collapse, cardiomyopathy, developing retinopathy, and an elevated C16-hydroxy on newborn screening. That combination is classic for LCHAD deficiency. The single most discriminating feature is retinopathy. Comparing the disorders, LCHAD has the newborn screening markers C16-hydroxy and C18:1-hydroxy, has cardiomyopathy, and uniquely has retinopathy, and it also commonly has neuropathy. Very long-chain acyl coenzyme A dehydrogenase deficiency has a C14:1 marker and cardiomyopathy, but no retinopathy. Medium-chain deficiency has a C8 marker and no cardiomyopathy and no retinopathy. So retinopathy is the unique clinical fingerprint of LCHAD among all the fatty acid oxidation disorders. Question 7. A metabolic genetics specialist sees 2 siblings. The older child, age 5, has isolated LCHAD deficiency confirmed by enzymatic assay. The younger child, age 2, has deficiency of all 3 enzymatic activities of the mitochondrial trifunctional protein. Both have elevated C16-hydroxy on the acylcarnitine profile. Compared to isolated LCHAD deficiency, which statement about complete trifunctional protein deficiency is correct? Option A. Trifunctional protein deficiency exclusively affects the HADHB gene encoding the beta subunit only. Option B. Trifunctional protein deficiency results in deficiency of all 3 mitochondrial trifunctional protein enzymatic activities, namely enoyl coenzyme A hydratase, LCHAD, and thiolase, whereas isolated LCHAD deficiency affects only LCHAD activity. Option C. Trifunctional protein deficiency does not cause peripheral neuropathy, unlike isolated LCHAD deficiency. Option D. Trifunctional protein deficiency has a milder phenotype than isolated LCHAD deficiency. The correct answer is option B. The mitochondrial trifunctional protein carries 3 enzyme activities: enoyl coenzyme A hydratase, long-chain 3-hydroxyacyl coenzyme A dehydrogenase, and 3-ketoacyl coenzyme A thiolase. In isolated LCHAD deficiency, only the LCHAD activity is lost, while the hydratase and thiolase remain active. This is typically caused by the C.1528G to C mutation in the HADHA gene. In complete trifunctional protein deficiency, all 3 activities are lost, and this can result from mutations in either the HADHA or the HADHB gene. Option A is wrong because trifunctional protein deficiency is not limited to the HADHB gene. Option C is wrong because trifunctional protein deficiency can also cause peripheral neuropathy. Option D is wrong because trifunctional protein deficiency actually tends to have a more severe neonatal presentation and a worse overall prognosis than isolated LCHAD deficiency. Because the acylcarnitine profiles look similar, the enzymatic assay in fibroblasts is required to distinguish the two. Question 8. A 3-month-old girl with LCHAD deficiency is discharged after her first metabolic crisis. She is formula-fed. Her parents ask which dietary strategy is most important to prevent future crises. What is the cornerstone of long-term dietary management in LCHAD deficiency? Option A. A high-protein, low-carbohydrate diet to stimulate gluconeogenesis. Option B. A ketogenic diet to bypass fatty acid oxidation and provide ketones directly. Option C. A low long-chain triglyceride diet with medium-chain triglyceride supplementation as the primary fat source. Option D. Eliminate all dietary fat and use total parenteral nutrition for the first 2 years. The correct answer is option C. A low long-chain triglyceride diet with medium-chain triglyceride supplementation. Long-chain fats, those with 14 or more carbons, cannot be processed in LCHAD deficiency, so they accumulate as toxic hydroxy metabolites that damage the heart, retina, and nerves. Medium-chain triglycerides, the C8 to C10 fats, bypass the defective LCHAD step entirely. They are absorbed directly through the portal system and enter the mitochondria without needing the carnitine shuttle, providing safe energy with no toxic accumulation. Typical dietary targets are long-chain fat at about 10 to 20% of energy, just enough to cover the essential fatty acid requirement, medium-chain triglycerides at about 30 to 35% of total energy, and frequent feeds every 2 to 3 hours to avoid fasting. A ketogenic diet must never be used because it actually worsens toxicity. LCHAD patients cannot oxidize long-chain ketone precursors. Question 9. An 8-month-old known to have LCHAD deficiency presents with 18 hours of vomiting and poor feeding from a rotavirus infection. The glucose is 1.2 millimoles per liter. The pH is 7.12. Lactate is 7.8. The creatinine kinase is 12,500 units per liter, and the corrected QT interval is prolonged. What is the most critical immediate intervention? Option A, intravenous dextrose, 10% or higher, to restore glucose and suppress fatty acid catabolism with cardiac monitoring. Option B, intravenous sodium bicarbonate as first line to correct the metabolic acidosis. Option C, intralipid infusion to provide an energy substrate. Option D, oral medium-chain triglyceride oil via nasogastric tube to restore energy. The correct answer is option A, immediate intravenous dextrose with cardiac monitoring. Intravenous dextrose is the critical first step. It restores blood glucose immediately, and just as importantly, it suppresses the mobilization of endogenous long-chain fatty acids, which stops the production of toxic metabolites. The target glucose infusion rate is about 8 to 10 milligrams per kilogram per minute, aiming for a glucose above 100 milligrams per deciliter, because the goal is to achieve anabolism, not merely a normal glucose. The prolonged corrected QT interval means continuous cardiac monitoring is mandatory, and all QT prolonging medications must be avoided. Two options are specifically contraindicated. Intralipid, an intravenous fat emulsion, contains long-chain fatty acids and would worsen the toxicity. And oral medium-chain triglyceride oil is inappropriate while the child is vomiting. The intravenous route is mandatory in this situation. Bicarbonate is not the first-line answer, because correcting the energy deficit with dextrose addresses the underlying cause of the acidosis. Question 10. The parents of a 2-year-old with LCHAD deficiency who has had 3 prior hospitalizations despite compliance with medium-chain triglyceride formula ask about a newer treatment they heard about at a metabolic conference. Regarding triheptanoin, brand name Dojolvi, in LCHAD deficiency, which statement is most accurate? Option A, it is an even-chain medium-chain triglyceride, providing the same metabolic benefit as regular medium-chain triglyceride oil. Option B, it is a long-chain fatty acid supplement that restores beta-oxidation capacity. Option C, it is only approved for very long-chain acyl coenzyme A dehydrogenase deficiency with no evidence in LCHAD. Option D, it is an odd-chain, C7, triglyceride, providing anaporotic substrates, approved for long-chain fatty acid oxidation disorders, including LCHAD. The correct answer is option D. Triheptanoin, brand name Dojolvi, is an odd-chain C7 triglyceride. When it undergoes beta-oxidation, it is metabolized to both propionyl coenzyme A and acetyl coenzyme A. The propionyl coenzyme A is converted to succinyl coenzyme A, which enters the Krebs cycle and replenishes depleted cycle intermediates. This replenishment is called anaplerosis. Regular medium-chain triglycerides, the C8 and C10 fats, yield only acetyl coenzyme A and therefore have no anaplerotic effect on the Krebs cycle. Triheptanoin is approved by the United States Food and Drug Administration for long-chain fatty acid oxidation disorders, including LCHAD, very long-chain acyl coenzyme A dehydrogenase deficiency, and trifunctional protein deficiency. Clinically, it can reduce hospitalizations, improve exercise tolerance, and improve cardiac function. Question 11. A 4-year-old girl with LCHAD deficiency on medium-chain triglyceride formula since day 5 of life presents for an annual ophthalmologic review. She has no visual complaints, and her parents report normal vision. Dilated fundoscopy reveals early peripheral pigmentary changes in both eyes, and electroretinography shows decreased cone responses. Regarding LCHAD-associated retinopathy, which statement is most accurate? Option A, retinopathy in LCHAD is identical to retinitis pigmentosa from RPGR mutations with the same prognosis. Option B, LCHAD retinopathy typically begins in the macula and spares the peripheral retina until late stages. Option C, LCHAD retinopathy can progress to legal blindness despite good metabolic control, and docosahexaenoic acid supplementation may help slow progression. Option D, retinopathy in LCHAD is fully reversible with strict dietary management and resolves by age 10. The correct answer is option C. LCHAD retinopathy can progress to legal blindness even with good metabolic control, and docosahexaenoic acid supplementation may help slow that progression. Retinopathy affects roughly 80% of LCHAD patients, making it the most common fatty acid oxidation disorder with retinal involvement. The peripheral pigmentary changes progress centrally over time. Crucially, it progresses despite good metabolic control because the photoreceptor damage follows an independent mechanism, so families must be counseled on a realistic prognosis. Electroretinography detects damage before visible fundus changes appear, making it the earliest diagnostic tool, and an annual dilated examination with electroretinography every 2 to 3 years is recommended. Docosahexaenoic acid becomes depleted because of the dietary fat restriction, and the retinal photoreceptors depend on it, so supplementation is used in many centers. Option B is wrong because the changes begin peripherally, not in the macula. And option D is wrong because the retinopathy is not reversible. Question 12. A 2-day-old neonate presents in metabolic crisis. Chest X-ray shows severe cardiomegaly. Echocardiography shows dilated cardiomyopathy with an ejection fraction of 28%. The electrocardiogram shows a prolonged corrected QT interval of 520 milliseconds. After intravenous dextrose stabilization, the parents ask about the cardiac prognosis. Regarding cardiac disease in LCHAD, which statement is most accurate? Option A, cardiomyopathy is a major cause of neonatal mortality, but is often reversible with metabolic stabilization and dietary treatment. Option B, cardiomyopathy is irreversible, and all affected patients require cardiac transplantation by age 2. Option C, cardiac disease in LCHAD is exclusively arrhythmic with no structural heart disease. Option D, LCHAD cardiomyopathy is hypertrophic only and never presents as a dilated form. The correct answer is option A. Cardiomyopathy in LCHAD is a major cause of neonatal mortality, but it is often reversible with prompt treatment. The neonatal period carries the highest risk because cardiomyopathy, arrhythmia, and metabolic crisis can combine and be rapidly fatal. However, with intravenous dextrose leading to metabolic stabilization, followed by a low long-chain triglyceride diet with medium-chain triglyceride supplementation, cardiac function can recover. Annual surveillance is required, with echocardiography and an electrocardiogram every year, partly to monitor the corrected QT interval. Both dilated and hypertrophic forms of cardiomyopathy can occur, and if the cardiomyopathy does not resolve, referral to pediatric cardiology is appropriate. Option B overstates the prognosis, since not all patients need transplantation. Option C is wrong because there is real structural heart disease, and option D is wrong because the dilated form is common. Question 13. A 7-year-old boy with known LCHAD deficiency on dietary treatment presents for an annual neurology review. His parents report 6 months of progressive clumsiness and frequent tripping. Examination reveals decreased ankle-deep tendon reflexes, reduced vibration sense in the feet, and mild distal muscle weakness. The resting creatinine kinase is 850 units per liter. Regarding peripheral neuropathy in LCHAD deficiency, which statement is correct? Option A, it is entirely preventable with strict dietary management. Option B, it is a pure motor neuropathy affecting only the lower limbs. Option C, it occurs in less than 5% of patients and is clinically insignificant. Option D, it is a progressive sensory motor polyneuropathy in about 67% of patients, and it worsens with metabolic crises. The correct answer is option D, a progressive sensory motor polyneuropathy that affects roughly 67% of patients and worsens with metabolic crises. This makes it the most common neuropathy among the fatty acid oxidation disorders. It is sensory motor, meaning there is both sensory loss and motor weakness, so option B is wrong. The mechanism is toxic. The three-Hydroxyacyl metabolites damage Schwann cells. The distribution is distal more than proximal, and lower limbs more than upper limbs, producing the classic glove and stocking pattern of sensory loss. Rhabdomyolysis can also occur, with creatine kinase elevation triggered by exercise, fasting, or illness. Annual nerve conduction studies are recommended for monitoring. An important contrast, unlike the cardiomyopathy, which often responds to dietary treatment, the neuropathy is frequently resistant to dietary treatment, so it must be monitored proactively. This is why options A and C are incorrect. Question 14. A 28-year-old woman at 34 weeks of gestation presents with jaundice, right upper quadrant pain, and fatigue. Laboratory tests show severely elevated liver enzymes, low platelets, hemolysis, coagulopathy, and hypoglycemia. After delivery, her newborn male is flagged on newborn screening. What most likely explains the mother's severe pregnancy complication? Option A, coincidental viral hepatitis unrelated to the pregnancy. Option B, fetal LCHAD deficiency, where toxic metabolites cross the placenta and overwhelm the heterozygous carrier mother, causing acute fatty liver of pregnancy or HELP syndrome. Option C, autoimmune hepatitis triggered by pregnancy hormones. Option D, the father's LCHAD carrier status causes maternal liver disease. The correct answer is option B. This is one of the most important and unique associations in LCHAD deficiency. Here is how it happens. The fetus has LCHAD deficiency and cannot metabolize long-chain 3-hydroxy fatty acids. These toxic metabolites cross the placenta into the maternal circulation. The mother is an obligate heterozygous carrier, so she has reduced LCHAD capacity herself and cannot clear the fetal metabolites, which leads to liver toxicity. The result is acute fatty liver of pregnancy or HELP syndrome. About 79% of LCHAD-affected pregnancies are complicated by acute fatty liver of pregnancy or HELP in the mother. Recognize the pattern. Jaundice with right upper quadrant pain and coagulopathy suggests acute fatty liver of pregnancy. Hemolysis with elevated liver enzymes and low platelets defines HELP, and maternal hypoglycemia is a marker of severe acute fatty liver of pregnancy. The key action is that any mother with acute fatty liver of pregnancy or HELP should have her newborn urgently tested for LCHAD deficiency. Delivery is the treatment for the mother, and the newborn needs immediate metabolic evaluation. Before we close, I want to invite you to support and join our community Pediatric Case Review on Patreon. Supporting us helps keep this high-quality clinical education completely free. Inside the community, all of the videos are systematically arranged by body system, so you can access everything in one place for structured self-study. Every presentation is also available to download as images, so you can review and practice all of the questions offline, anywhere. There is a growing library of case-based clinical lectures, with new content added regularly. If you would like to subscribe, just leave a comment below this post, and we will message you directly. Let us bring it all together with the key takeaways for LCHAD deficiency. First, the hallmark triad: hypoketotic hypoglycemia, cardiomyopathy, and pigmentary retinopathy, with retinopathy being unique to LCHAD among all the fatty acid oxidation disorders. Second, the newborn screening marker: elevated C16-hydroxy, Z18-hydroxy, and C18:1-hydroxyacyl-carnitines on tandem mass spectrometry, where the hydroxyl group is the biochemical signature. Third, the cornerstone of treatment: a low long-chain fat diet with medium-chain triglyceride or triheptanoin supplementation and avoiding fasting at all costs. Fourth, the emergency rule: give intravenous dextrose, 10% or higher, immediately to suppress fatty acid catabolism. Never give intralipid, and cardiac monitoring is mandatory. Fifth, retinopathy watch: it affects about 80% of patients and progresses despite good control, so an annual ophthalmology review with electroretinography is essential. And sixth, the maternal link: an LCHAD-affected fetus can cause acute fatty liver of pregnancy, or HELP, in the carrier mother. So always screen the newborn when the mother has acute fatty liver of pregnancy, or HELP, in the carrier mother. Thank you for joining this Pediatric Case Review lecture on LCHAD deficiency, and thank you for your dedication to pediatric clinical education. If you found this helpful, please follow the channel for more case-based pediatric lectures. And if you have any questions, leave them in the comments and we will be glad to respond. Remember, this content is intended for educational purposes only and does not constitute direct medical advice. Always consult current guidelines and specialists for clinical decisions. We will see you in the next lecture.